I'm super excited that we had a lunch break between me and Greg. I can't really, he's a hard act to follow for sure. They're super fast. All right, so when Rajam asked me to come up with something to talk about regarding pain, Sandy Hilton is actually the one out of the two of us, I think, better known for her talks on pain and such. But something I see a lot in the clinic is actually women during pregnancy and postpartum. And there's a lot of common misconceptions out there regarding that it should hurt. So people expect it to hurt, they accept that it hurts, they don't seek help when they hurt. Please note, I'm not talking about delivery. Ray and I had an interesting discussion about delivery could feel better with certain interventions, but I do think disclaimers are important. I do work in co-own Entropy. We host a ton of continuing education courses that are amazing. Again, huge bias on my part. But then also, I am really biased in my practice to thinking that women and men are strong and resilient beings. So I do believe people can get better. I do believe people can do a lot to help themselves. All right, so pregnancy. So I've never been pregnant. I've not gone through that. It's amazing that women can do this. They can produce a person over the course of 40 weeks. So these are some common things that happen during pregnancy. So you gain weight in a lot of different places. And we know that adding weight can make you feel differently, but there's just a lot of things going on, up to 24 pounds on average, but up to 75 extra pounds. It's like an extra leg. Okay, during the first trimester, women will experience some morning sickness, some soreness in their breasts, frequency of urination, not because of the fetus pressing on their bladder, it's just totally hormonal. And then constipation, also totally hormonal and not much fun either. And then moodiness. Second trimester, some people tend to feel a little bit better, but they continue to have some issues that are different than when they're not pregnant. And then the third trimester, this is when you have like an actual baby on the inside that could make it on the outside of the world. And all of this stuff makes sense. The breathlessness, it's hard to breathe. Baby's pushing the diaphragm up and you can't really expand your lungs. You get swelling, possibly preeclampsia. Luckily, that's not the case for everyone. So there's a lot of things that happen. And this is one of my favorite pictures because if you look at the picture on the left, the stuff inside of us it's packed in there pretty well. There's not tons of extra space floating around. And then we put in a child, and everything smushes out of the way. It's amazing to me how the bladder gets smushed down so far, and everything else gets pushed up so far. It makes sense that how you move is going to change, how you hold yourself is going to change. It has to change. That being said, this is not easy. Like, to be able to do this, I feel like it takes a lot of work. And then the baby has to get out. And I just have a vaginal delivery here, but regardless of how that baby comes out, it's a commitment. And there's really not an easy way. So sometimes people will be like, well, isn't a C-section a little bit easier? Honestly, no. Recovery is about the same. All right, so can I see a show of hands? How many people here think that having pain and hurting during pregnancy is normal? Okay, so yeah, so there's some discomfort, and I'd say it's about as normal as having pain at any point in your life. Yeah, so pain is a normal part of life. It's to be expected. But during pregnancy, it's almost like people are like, well, you're pregnant, what do you expect? Where if like you come up and you say your back hurts, people are like, well, let's see what we can do about that. So yeah, nope, not really. But really, most women will experience some kind of low back pain or pelvic girdle pain during their pregnancy. So I decided to focus on a couple of the most common complaints. Low back pain and pelvic girdle pain are two things that some women experience both. Some people experience one more than the other. Round ligament pain, which that'll be a fun discussion. Hopefully, we'll have some questions at the end. And then diastasis rectus abdominis, or diastasis recti. Oh my gosh, now I'm forgetting. I believe that Mark talked about definitions, and I think definitions are really, really important. So we understand what we're talking about. I don't know if you guys have ever had someone come to see you and they say, my hip hurts, and then you're like, all right, where do they hurt then? So does their hip hurt? Does their hip hurt? Does their hip hurt? So having a definition as to what we're considering low back pain, I think, is important. Typically in research, it's talked about from the 12th rib to the lower gluteal folds, with or without referred pain. And then pelvic girdle pain. This is from the European guidelines. Pelvic girdle pain is often defined as any pain between the iliac crests and the lower gluteal folds. So that kind of crosses over, yeah? Low back pain definition actually includes a lot of what we would consider pelvic pain, except this does include possibly pain into the front in the pubic symphysis. Clinically, and in the guidelines, they talk about the pelvic girdle pain is very frequently noted during transitional movements. So low back pain, you might feel it when you're sitting, you might feel it when you're walking, but a lot of times with pelvic girdle pain, it's like that transitional movement, sit to stand, rolling, stairs are another one. All right, so I mentioned that it was going to be very, very common. It is indeed. So 56 to 72% of women will experience low back or pelvic girdle pain during their pregnancy. It's not surprising that usually women experience some more of it as the pregnancy moves on. And one of the things they found looking at all the research is that there's an increased risk of experiencing low back pain if the woman has had a previous episode of low back pain. And that kind of makes sense, yeah? Because it's the same in the general population. So if you have an episode of low back pain, and most of us will have an episode of low back pain, you are more likely to experience it again later. So if you look at these numbers, it actually kind of surprised me that how similar they were as far as how many pregnant women would experience low back pain compared to the general population. However, if someone came in with low back pain, we don't go necessarily, don't worry about it. Pregnant women, we do, which I think is really interesting. All right, there's a lot of opinions and thoughts on what might be the cause of low back pain or pelvic girdle pain during pregnancy. These are some of the common beliefs, the things I've actually heard patients tell me their doctors told them, things I've actually heard come out of physicians' mouths, things obviously that you'll find if you Google low back pain in pregnancy, is that it's the extra weight, obviously. The center of gravity is different, and definitely way too much lordosis. It's the cause of all low back pain. And then the relaxin, and what can you do about that? Not a thing. The good news is, one, we really don't know. So I think sometimes people will start, they want to attribute it to something, right? Like they want to be like, this is why this is happening. But really the fact of the matter is, we don't know. So telling someone it's because your low back is arched too much isn't really fair. Especially, I've had some patients feel better when they had more lordosis. But people tried to fix them and have them come out of that. And it's really funny how that lack of communication and that lack of understanding really caused that person to keep hurting. So what do we know? The good news is all of this stuff that is really going to happen when you're pregnant. Your center of gravity shifts, as it should. You're going to get heavier, as you should. And that increased lordosis, I think, is just a clever way of your body adapting. Really, there's moderate evidence that we really don't need to worry about this, that it's not indicative of developing it, and it's not really a sign that you're going to have more pain in your low back or your pelvis. So that's good news, I think. So we need to stop telling people that that's their problem. And I think in this room, I'm kind of preaching to the choir. I think a lot of us already have embraced that. But I think we need to tell more people and figure out how to start to dispel that myth that how you're standing and the fact you're just going to get heavier, so the baby will be out eventually and then you'll be okay, isn't really fair or accurate. All right, so relaxin. This was kind of fun for me to look a little bit more into it. I am not going to claim to be an expert on hormones, but so often that's what we would blame what would be blamed for the pelvic girdle pain, right? So we have our 3 joints in the pelvis. You know, the hips are going to spread. What are you going to do? This is an awesome adaptable thing because that baby's going to have to come out. Like we have to fit a whole person on your insides. It's a really good thing that things stretch a lot. However, something that was never talked about, so when women are like, well, it's the relaxin, good luck with that, it impacts all of you. It impacts all of your joints. It impacts your tendons, your muscles, your cartilage. It's everywhere. So it made me question, obviously every pregnant woman is going to have a degree of relaxin, right? I mean, they have to. That amount does vary, which is interesting, but also it's impacting all of our joints. And we're not going to say, oh, your ankle hurts because of the relaxin, right? So it's really got me thinking. So I think that we don't have to blame the relaxin. That's something that's going to change over the course of the pregnancy and go back to normal after they're done breastfeeding. This is a point I really like to talk about, though, because I have also, again, in the clinic, had women consider to stop breastfeeding because your relaxin levels stay elevated while you're breastfeeding. But we know there's benefits, right, to breastfeeding for an infant. We don't know that there'd be any change. In fact, I'd say it's highly unlikely there'd be any change in their pain if they stop breastfeeding. So they were being given advice that would not be good for their baby and probably not be helpful for them. So I think understanding this is really important. All right, round ligament pain. I'm just gonna ask for a show of hands for the ladies who have been pregnant. How many of you guys experienced round ligament pain? Or what was diagnosed as round ligament pain? So I feel like this is a kind of a controversial thing. I was really curious about it, so I Googled it. I started with Google Scholar because I could not ever find a scholarly article on round ligament pain. So when I did Google Scholar it was a lot of fun. I found nothing but information on varicosities of the round ligament and nothing about round ligament pain specifically in pregnancy. So I did find this definition, that it's a pain associated with the round ligament of the uterus. It's very important to ascribe pain to some kind of physical structure, right? No. But this is a definition we found. Usually during pregnancy, it's one of the most common discomforts of pregnancy. And that little one, I'm going to tell you where that reference was from in a moment, because this entire reference was from Wikipedia, because I couldn't find any. So while I understand very, very much that it is not uncommon to have pain in the anterior part of the pelvis and lower belly during pregnancy, I think going, it's round ligament pain is really very fair or accurate. So that number one reference was from mama.com or something. It was not even from a medical textbook. So I'd like to, again, challenge people. If you get a person who's saying, I'm having round ligament pain, what we really do is we try to kind of translate that into, all right, tell me more about when this is happening. Do things make it better, make it worse? Let's really look at how it's impacting them, because there's nothing we can do to change that round ligament anyway, even if it was the issue. Sorry, I'm talking a little bit fast. All right, so diastasis. How many people in here assess for or look at diastasis? Okay, and when we're looking for it, how many of us are looking at it just because we're curious? How many of us are looking at it because the patient wants us to look at it? Okay, and then once you decide it's there or not, how many of you know exactly what to do? Excellent. So if you don't know what a diastasis is, we have our six-pack muscles, in the front, our rectus, and they separate. So this isn't a tearing, it's not a hernia, it is literally just stretching of that connective tissue in between those muscle bellies. And that's all it is. Again, thank goodness, because when you stretch those muscles out, there needs to be a little bit of a pressure release valve. So there's no real agreement as to what's normal. There haven't been any large studies that talk about that we could assess everyone in this room, male and female, with a real-time ultrasound and see, how far is far enough. I was trained from the very beginning that basically 2 fingers width in between is normal. But even that, what does that mean? I don't know. It was one of those things where once I learned to assess it, I was very confused as to what I was going to do with that information. What if it was smaller? What if it was bigger? When does it start to become an issue, something that needs to be addressed? It's a mystery. But the interesting thing is, again, I've been doing pelvic health and women's health for probably close to 15 years now, and the diastasis has been blamed for lots of things. It's associated with prolapse, it's associated with incontinence, low back pain, all of these things that would be fixed if only we could address the diastasis and have that be fixed. The good news is, since we really can't fix it, that as time has gone on, we've learned this doesn't actually, it's not really associated with pain at all. So in a study with Kari Bo, she couldn't find any difference between women with and without a diastasis 12 months postpartum. So you could hurt with a diastasis, and you can hurt without a diastasis. So it's maybe not necessary to look at something you're having trouble changing as the sole contributor to the symptoms that they're having. Okay, so but what about pelvic floor dysfunction? A lot of us know, or we look at like the core as like a canister, the rectus abdominis is part of that, the pelvic floor is part of that. So isn't there this relationship where if we have something not working quite right in the abdominal wall, that obviously the pelvic floor is going to have issues, we're going to have issues stabilizing our core and stuff? No, we've really not found anything there either as far as with pelvic organ prolapse or pelvic floor dysfunction. So again, I always look at this as like really good news, because for some women, the diastasis becomes a real source of concern, but it's a really hard thing to change. So we'll talk a little bit more about that in a little bit. So we've defined, like, we've taken a look at round ligament pain, back pain, pelvic girdle pain, diastasis, and if it does or doesn't matter. But really just, I think pregnant people are just still people, and sometimes people have pain. Thank you. I didn't think I'd get any laughs like Greg did. And sometimes people, how many people in here will treat a pregnant person and not think twice about it? Okay, so most of you, which makes me happy. I've worked in clinics where if someone was pregnant, they didn't even know what to do. Like, they're just like, Sarah's here, send her to her. And really, pain during pregnancy isn't that different. There might be some different contributing factors. Things are obviously changing. But a lot of times if you go, how long have you had this pain? They're like, oh, since my first kid. So now is this a pregnancy issue? Or is this just an issue that's going on and now has become important enough to address? So hopefully if someone who has had low back pain who happens to be pregnant is a little bit less intimidating now than a delicate flower who's pregnant in front of you now. Here's another thing. So this slide, I got it properly attributed to the article, but I saw this last week at the Sports Congress, and it just made me so happy. The words at the bottom, the relative contributions of each domain of the biopsychosocial model to patients' presentations are neither predetermined nor static, and their relevance and contribution may vary between patients. And I think that's so important to remember. So often we start to hear these discussions of, and I mean, that was basically Greg's talk, right? That, when does the bio matter? When do the biomechanics matter? When they matter, really. And obviously, when you're pregnant, there's a lot of bio going on, a lot of bio. And that bio is changing over the course of 40 weeks. And then, I'm not even talking about postpartum, but I'll just throw this part in there. Then that baby comes out in 1 to 2 days, and everything changes again. And they hand you that child or children and are like, good luck, right? So there's a lot going on there. And it does change. But I will tell you that my very first pregnant patient ever, this was long before I thought about going into it as a specialty. I knew nothing. But she came in, and I was like, all right, hip pain. All right. Oh, she happens to be pregnant. Okay. Then you start taking that history, that subjective. So she's 42, which is technically advanced maternal age. She had been through probably close to 40 rounds of various fertility treatments, and she had been through 14 miscarriages. Yeah. And she, prior to this, had no pain ever. But once she found out she was pregnant this time, she put herself on bed rest. And most of us know that if anything hurts, if we just go crawl into bed, it doesn't really feel better. So here is a gal where actually, in spite of being pregnant and having a high-risk pregnancy, really, her bio was probably the smallest bubble. Her psycho, huge, right? The social, also tricky. During this time when I was seeing her, also her husband lost his job, just as they were building a new home. And so there was a lot of stuff. And again, even though the bio was super important in her case, to be honest, this was like the psycho and the social were the two biggest things. And luckily, I think I luckily got it right, just because I didn't know what else to do. I rubbed her bum, put her in the pool, and we had really nice chats for a half an hour twice a week. And yeah, and she did okay. She's fine now. That was like 15 years ago, though. So let's talk about why pain might be different during pregnancy. There's a lot of reasons. And so I know this is a little bit small, so I will read it. I was a little nervous about one of the pictures, but then Greg swore a lot, so I'm not nervous anymore. But so when a lady is pregnant, so she's expecting, now even just that part can be complicated. Let's say that you're like my first patient ever, who was so excited about being pregnant and wanted so desperately for this to be a pregnancy that could go to term, that she literally put herself on bed rest. But let's flip that and you found out that you're pregnant, and this is the worst news you have had ever, right? And you're not sure what you want to do about it. Like what you're going to do, like becoming a mother, these are all things that start to be part of like this picture, right? So you're worried about the health of the baby. You're wondering if you're going to recover from it. I had a meme that, honestly, quite frankly, I forgot to put it in, but it was basically a lady just going like, I wonder if my vagina is ever going to recover. And she was like on the phone with a friend. But it's true. Like you start to wonder, will anything be the same again? And then also there's stuff like, what are you going to do? So if you're early 30s or 40s, right? You have your career, you've been you for so long, and now you have a baby. So what are you going to do with your job? My first patient ever, she had, before she was even pregnant, left her job to focus on having a baby. But you know, if you're a professional with a career that you love, you have to think about that. And then of course you have to be ready to be judged for that. Because if you go back to work, a lot of people have things to say. If you don't go back to work, people have things to say. And you have to decide what that means for you and your family. That's a lot to think about, right? You have anxiety about maybe that partnership you have with whomever you're having a baby with, if you've chosen to have it with someone. So that's another thing, is if you have your lover and your best friend and now all of a sudden you're parenting. That changes the dynamics a bit. And if you really love how things are, the idea of a little person coming along and changing that's a stressor. It might be fantastic, but it also might change things that you really like the way they were. Unsolicited advice. That's what the middle fingers are for. Everyone has something to say about what you should be doing while you're pregnant, how you should recover. What I did totally worked so good. Like I said, I've never even been pregnant, but I hear these things people tell people to do. It's got to be maddening. And even just trying to figure out, while you're pregnant, what are the best things to do? So, you know, can you have that glass of wine or can't you? Should you be taking the prenatals or shouldn't you? But there's just tons of advice, and especially, like, again, Google it. You're going to get conflicting advice all over the place. And sometimes you even end up getting conflicting advice from your healthcare practitioners, which is even more confusing. So if a doctor says that's your round ligament pain and that's going to be terrible for the rest of your pregnancy, and then someone comes to see me and I was like, well, I don't know, let's try some things and see if you feel better. Even that can be conflicting and confusing and not helpful. Okay, so what do we think we can maybe do to help pregnant people who happen to be hurting? I propose that really we don't treat them much differently. Obviously, there are a couple of different things we need to take into account. There is a biological change. These people can't lie on their stomach. Their exercise tolerance is going to change. There's a lot of different things. However, I really think that we need to start with just treating them like people who hurt. All right, so some things we can do. Exercise. I was told I needed more kittens in my presentation, so Kirby, here you go. So exercise, so speaking specifically to pain, to pelvic girdle pain, exercise once a week substantially reduced the risk of pelvic girdle pain. So that's fantastic news. We know that exercise is good for pregnant people and just people. So it kind of works. And non-specific exercise was recommended in this guideline for just general health, also low back pain, also pelvic girdle pain, and also diastasis. So if you're not sure what else to do, let's try to get them moving a little bit. And this is just once a week. They did find that if you were exercising like more than 3 times a week, you didn't get more benefit, but you know, at least getting moving is going to be a good start. So is it safe for pregnant women to exercise? How much is enough? Or what's too much? What's not safe? It is safe, and most guidelines, I read a review that had exercise guidelines from 3 or 4 different countries, and what they found is that regardless of the country and regardless of the actual amount recommended, there wasn't a single country that was where women were regularly meeting the exercise recommendations for pregnancy. So women do need to move more, and I think that we have a fairly strong argument that moving more will likely help them feel better. And really, as far as what's the best way to know it's safe, the talk test. So if you're exercising cardiovascularly and you can still carry on a conversation, you're in pretty good shape. So this is actually a gal I did see run the marathon. And it was like one of those things where it's like you're watching all these people run and you're thinking, good on them. I'm really not interested in running a marathon. But then this lady runs by with a big belly, and you're like, and then I found this in one of the Chicago papers. So there are some contraindications for exercise during pregnancy, and I have them listed here, and I'll have Rajam share my slides with you. But the neat, I don't know if it's the neat thing, but the thing we do know about pregnant women, at least in America, these are the people most closely followed by physicians. I mean, they are checking in monthly to start with, and then they start going in weekly. So the cool thing is if there is something that seems funny, they are already in the system. You can call the doctor and ask, and they're already being monitored regularly. So you'll know if any of these contraindications or relative contraindications need to be followed, which is, it's really nice. So the lady who ran the marathon, they actually wrote up a paper on her because people were absolutely outraged that this woman would put her child at risk by running a marathon when she was 9 months pregnant. Actually, what she did is just induced herself into labor, which was fine because she was due. And so, you know, people talk about spicy food, this and that, like, maybe more exercise. But this little graphic on the left is basically just showing all the ways she was safe. She was safe. She didn't run really, really fast. She had support crew. She had adequate hydration and food. So this idea that pregnant women are delicate flowers is really out of date. It is really possible for pregnant women to do whatever the heck they want. And honestly, as a physio, I think it's my job to help them do that. It's really not my job to say, why don't you take it easy? You work with them and help them overcome those things. Okay, so diastasis. Again, I mentioned that it's really not a thing that we think is contributing that much to pain, which is cool. However, women want to fix it. They want it fixed. We can't fix it. So I think it's really important. We were talking, again, Mark mentioned, don't make promises you can't keep. Don't say, in 5 days you're going to be better. Really, what I think women need regarding this is some honesty, that it's going to get better regardless of what you do. And if you're still not happy with it in, say, like 4 months, there might be some exercises we can work on. My big problem, I don't know what slide, oh yeah, is that people will tell people stupid things that aren't true. So women who have diastasis, let's think about how they got that, yeah? We started out with something very small in their stomach, and we stretched this tissue over the course of 40 weeks. And then one day, we took out everything that stretched it. So this is not tissue that is going to stretch too much. It is already stretched about as far as humanly possible. But people will be told they can do things to make it worse. And I have found no evidence that like twisting or bending will make it worse. So I think that's one thing that we can tell people is to please move and to not be scared. And also there's no evidence of any exercise program of speeding up or enhancing recovery. There are, however, many commercial things available, if you're interested, that assure you they can. I decided to challenge my biases, mostly because Neil's in the room, and so that I could make sure I knew what I was talking about. So the one program I did look at that was evidence-based and supported by research, it was lovely. It was one article that was, I think it had eight participants, and it compared this particular program's exercises, very specific, and people doing nothing. But they're using it as proof that their program works. When really, when I read that, I was like, so doing something's better than maybe doing nothing. The other evidence they gave were these really beautiful graphs, and it looked like tons of information. So I was reading it, and really what it showed was just the progression of people who were in the program over 18 weeks. It didn't compare against people who were doing nothing or just walking or doing any other program. So they were really using science as a way to make it look like they could help fix a diastasis better, sooner. The difference that was found, Neil, I think you'd be proud of me, it said 5% difference. This was 0.1 centimeter difference on average of diastasis. So that's like a millimeter. It was a millimeter better. And I would say that's probably not significant. I didn't do the stats on that, though. So there is also a bit of evidence that we don't have strong evidence for exercise either, but there is a bit of evidence that exercising is better than doing nothing. But I think, again, that sounds pretty commonsensical for almost anything we're seeing. Doing a little something might be better than doing nothing. All right, and here, so when people come to see me and they mention a diastasis, or that's on the prescription, or that's a concern of theirs, I think it's my job to address their concerns. But if all they say is my diastasis, I really do need to know more. So I need to know, are they concerned with how it looks? Do they think it's contributing somehow to the pain that they're having? Or is it something where they think it's contributing to the incontinence they're having, or the pain when they're walking, or anything like that? So finding out, again, their narrative as to why it's concerning to them will tell you what you can do to help. Because we know, again, it's not necessarily a huge deal for the pain, so let's make sure we're educating them properly on the options, on the things that they can do, on the things that you can try. If it's function, so let's say I cannot imagine what it's like to, again, have a person on your inside, put them on the outside, and then try to like stand up straight. Those muscles were stretched out this far, and now they're really loose. Maybe something like an abdominal binder might help that person, or it might not. But if we're looking at the functional issues they're having, we can help get them moving, feeling strong and confident, and then, again, progressing them to where they feel like them again. And even aesthetics. So this is one of the things that I really, not to brag, I've had really good success with. Most women will come in, and what they've read is that they shouldn't do any abdominal exercises whatsoever. They have been scared to even get on a treadmill, and they're really just concerned with how it looks. And I'll be honest, I've had like 4 people this year. Each one has been one visit, and it's not that I'm an exceptional therapist, it's that I just told them to stand up straight. So if I have muscles that are here, there's nothing magic about posture, but if I'm concerned with like how things are looking here, and then I have you stand up straight, and things stretch out a little bit, and things seem to come together, they were so happy. And honestly, all that was untuck your bum, stand up straight, and please go to the gym and let me know if you have any questions. But again, that misinformation that's out there about what they're allowed to do and that they're going to make it worse somehow, we really need to get away from this idea that we're so delicate that one wrong move and boom, diastasis. It's just not true. All right, so manual therapy, we have tons of touchers and feelers in here, which is amazing. But what about using manual therapy during pregnancy? Absolutely. So when we talk about manual therapy, there's like joint mobilization, so I'm going to talk a little bit about this, is that it's kind of interesting to think about it, right? So we just talked about the relaxin, and pregnant people's joints do tend to be a little bit more lax. Should we be wiggling them more? Maybe. We'll talk about that on the next point, is that there's some thought. So they did some studies, and they're looking at relaxin, and they're looking at joint mobility, and it was more associated with asymmetrical joint laxity than just joint laxity in women who had pain. So in my brain, what that means is like if stuff is stiffer on one side than the other, that maybe it doesn't feel very good. That's my clinical take. So maybe a little extra wiggle on the stuck side will make things feel a little better. Maybe. But that would be my clinical reasoning for what I'm doing and why. So if you're going to do joint mobilizations on a pregnant person, you just want to look at what am I trying to accomplish? What have I looked at clinically? Why do I think this is going to help? Talk about it with your patient, and then give it a go. So for a lot of manual therapy, though, right, the person's lying down. But can pregnant women lie on their backs? And the short answer is they can. But it's really interesting because, well, the reasoning behind that is that if a pregnant woman lies on her back, sometimes what will happen is the inferior vena cava will be compressed, and then it's going to start to restrict blood flow not just to the fetus, but also to the mother. Sometimes it's funny, I think we forget about that, and the mother. But what's funny, at least in America, is when a woman comes in to give birth, we promptly put her into bed on her back. And it's funny how, like, what's going on? Anyway, so they do that. And really, like, women, I've had women come in a lot, and they were freaked out. They're like, I woke up on my back. That was a close call. No, it was you waking up maybe because you couldn't breathe, but you're okay. Because there's no way, like, we can't lock a woman down, right? Stay on your left side, please. They're going to move around. I've also had women really, really feel terrible because they felt best lying on their back. So they're like, I mean, I can lie on my back, I feel great, my pain is gone, but I'm always lying on my left side. And I go, why? I said, because I'll kill my baby. I said, no, you will not. Also, and also they talk about like optimal blood flow to the uterus and all this stuff. And again, those changes are nominal. So really my take on that is do what makes you most comfortable. So women don't wake up dead from rolling over on their back. It'd be all over the papers. We'd have security systems that would keep women from doing that. It's just not a thing. And an obstetrician that I worked with said, honestly, you could not hold a pregnant woman down. If she was experiencing this inferior vena cava compression, like it would be trying to drown someone. There's just not a way it's going to happen. But who cares what I say? Really, what does the science say? So when women have to undergo tests that require them to lie on their back, so like an MRI, standard practice is to position them into 15 degrees of left lateral position. So like 15 degrees, not very far. But what's really funny is that when they actually did a study, so this is just what they did. They decided that would be far enough, and they did it. But then they did a study and realized there's no significant improvement in blood flow until they're at least 30 degrees. So I kind of take that as if you're really worried, do 30 degrees. But otherwise, go based on how the lady's feeling. Because 15 degrees is probably just awkward, I feel like, and not really helpful. But also, so let's talk about the baby. Is the baby going to be okay? Another thing they found is that when there was some compression of the inferior vena cava, the reduction in blood flow happened, but a protective brain sparing effect started to happen. So baby actually changed blood flow and reduced its needs so that it was okay with less oxygen. It's how we have made it this far as humans. Okay, so then function. And again, as a physio, this is kind of what I think we're really, really good at. And so modifying activities can be really helpful. Telling people to not do anything is really, really not helpful. So helping people figure out a way to get from sit to stand without hurting would be awesome, because they're going to have to do that a lot. If they have other children, that's my other favorite thing, is when you have a lady who's pregnant, she has 2 more kids at home, and they're like, take it easy. That's not going to be a thing. So really looking at their specific needs and helping them work out a plan so they can continue to do the things they want to do and need to do in their daily lives. Support belts. This is another thing where, you learn something and then you go to the clinic and you use it and you're like, what am I doing wrong? And then you realize you're not doing anything wrong, it's just not the right thing. So there's a whole bunch of different support belts that are out there, and if they help, they help. Ironically, in my experience, SI joint belts make pregnant ladies who have SI joint pain feel worse, but it makes pregnant ladies who have pubic symphysis discomfort feel way better. I guess I just named it wrong. I don't know. But there's also a lot of them where people will put them on, and they're kind of their contraptions. Like they go up and they go over, and if you put them on and you're like, oh, that is better, they might be worth the effort. But a lot of times you'll see the picture of the really happy pregnant lady wearing this belt over her clothes, and you're like, I want to feel like she looks, and then you put it on and you're like, this is really awkward and doesn't feel that good, then it's not the right thing. So try it. If it helps, awesome. If not, it's not you, it's the belt. And then just really try to have people keep moving. Just whatever, and have it be something they love, in the pool, playing with their kids at the park. It really doesn't matter. And probably the best thing we can do, other than keep them moving, is to really just encourage them, give them reassurance, because even if they're not feeling better, so you're going to try stuff, you're going to hope that they can feel better. We know there's a lot of reasons why people don't feel better, right? There's a lot of, life's complicated. But the good news is most low back pain and pelvic girdle pain does get better after pregnancy, or weirdly enough, later in pregnancy. It's really weird. But then also, pregnant women cannot do things to make themselves worse. So they're worried if they take a walk and they have more pain that they've made something worse. It's just not true. They hurt more, and we should look at that. But I don't know, there's like this, even when I ask it, they have this fear that they're going to make the diastasis worse, they're going to make their pelvis worse. I don't know if that's coming from their insides or if they're being told this, but they're strong, resilient, they are making a person. There's no reason why doing anything actively is going to make them worse. So my take-home messages is that really pregnant ladies are pretty freaking tough. They have to be, right? Please don't say silly things to scare them. If you have a belief that would restrict the freedom of a pregnant woman, check it out in the evidence before you say it ever again. Like, just check it. Encourage them to keep moving. Moving is good. If they have trouble moving, help them move. That's what we do, right? We help people feel better so they can move more. And do things that make them feel better, not worse. So if that's a manual therapy treatment, if that's helping them get back to their favorite exercise class, if that's just unscaring them, do whatever you can to help them feel better. That's it. We have a question in the front, and in the back, and over here, and over there. Goodness. Maybe, or a really bad speaker.
Sarah, you are the first speaker, I think, in years to actually catch me off guard.
Oh?
Yeah.
What did I do?
But you finished on time.
Oh, I was trying really hard.
All right, new record. So, first speaker, first question right up here.
Yes, so I do some of my work in sexuality, and something I've heard quite a bit is fears about dislodging, the fetus because most guys are huge. Obviously, it's a very common thing. But in terms of just physically accommodating, like how would you speak to a pregnant woman about having sex, whether she should be in certain positions, whether they should stick to manual versus penetrative? Like, what do you say?
Well, the cool thing is vaginas are super stretchy, so that the size shouldn't matter. But I would say definitely there's obviously some other stuff going on, and I think poking a cervix never feels very good. So I would talk about other positions to try that might change the position of the belly and of everything on the insides so that she could still have sex without having pain with the penetration. Sometimes, though, if they're having pelvic girdle pain or low back pain, also if you're not pregnant, again, other positions might make them more comfortable to have sex. So sometimes, standard missionary position puts you into a lot of flexion and you're getting smushed and that doesn't feel very good. Flip it over. But it really is more problem solving and specific to the person. So if they're like, it feels like this when I'm in this position, and problem solve, give them some options. That's their homework. Let me know how it goes. So yeah.
And we had a question from online.
Yes, we have 2 questions. The first is from Matthew Wright. In the event that another provider informed the patient that their pain is coming from a specific structure or location, do you have any tips on reconceptualizing this pain without seeming too conflicting with the other provider?
Yeah, that can be hard. And I think Greg kind of said it well right at the end, where I think he was being serious, was, it's not my job to kind of like confront and try to change their ideas or anyone else's, but I would really try to take it small and go, well, I'm here to help you, so let's just see. So even if that's true, let's try some stuff to help you feel better. So if you still think you have round ligament pain, and it's possible that is actually a thing, I just couldn't find it anywhere. Really what we want is like, okay, you have it, but we've been able to change it, so awesome. So yeah, so I'd say I would never undercut a former practitioner, one of their former practitioners, but I would try to just have them focus on the function and on the pain and be successful at that, I hope.
Okay.
We've got a question right up here towards the front.
Thanks, I really enjoyed that, particularly the diastasis rectus stuff, and pregnant women who have pain are just women who have pain who happen to be pregnant, so that's a great message. I'd really value your opinion on, you touched on the joint laxity relaxin thing, and that study that you mentioned about the asymmetrical laxity. I haven't seen that, so I'll look at that. But I know there's a couple of other studies, like one with the active straight leg raise, where the active straight leg raise is painful. It correlates with pain in the active straight leg raise, but not with anything else. And then the other one where they did that radiostereometric analysis, where they, God knows how they managed to get these women to volunteer, but they implanted markers in their pelvis and then fluoroscopic x-rayed them while they stood on one leg, and they found like 1/2 degree of rotation in the sacroiliac joint on both the painful and non-painful sides. Yeah, so I wonder what your kind of views are on that broader literature.
Well, so the active straight leg raise, I feel like a lot of those tests, I use them as like pre-post test maybe. So with the active straight leg raise, most of the time you'll also see with people that they can't lift up one leg in standing, right? Like they're like, I can do this, I can't do that. So I just take that as an issue with load transfer. Sometimes they'll use it, clinically we'll use it like, okay, so if I compress and now you can lift your leg straight, that you might benefit from an SI joint belt. My brain always goes back to one more step, so this is just the way I practice, is okay, so why can you lift one and not the other? is there something that isn't moving well? So that's where I usually go to the asymmetrical movement, and then actually usually, even though we assume pregnant women are loosey-goosey, there's probably a lot of stuff moving a lot more than it used to, but there might be a piece that isn't moving as much as it's supposed to. And I try to help move that, and I change it. So it's a provocative test, which is another reason why I don't do it tons, because most of the time people will tell me it hurts when I try to lift up a leg, and I believe them. So I don't probably use that test like as properly as they do in the research study. But to me, it is definitely it's a sign of like low transfer issues that you're going to see in other functional things. So that kind of answer. And the other thing, you were talking about the markers, but they saw the same change on both sides, painful and non-painful. Yeah, and that's when it was like, okay, so then it's not maybe the movement issues, like they're hurting for a different reason other than that. Yeah.
We had another question right in the very back, next by the camera, and then we had a question up here too. Okay, so you'll be next after him.
Thank you for a wonderful lecture on pregnancy and so on. Is there anything that would put you off using manual therapy or any time during that stage?
No, just if they hated being touched.
Okay.
Yeah.
Good answer.
No, if I think it's warranted and they're open to it, then I would do it. I honestly, in my practice, I don't do tons and tons of manual therapy. I keep it pretty minimal, and use it when I think it's most appropriate. Yeah, I mean, you would really in like the guidelines that were published last year here in America for pelvic girdle pain, manual therapy was, it said feel free to use it.
I agree with you. Complete agreement.
Right up here towards the front so Deborah, we'll have a mic coming up here for you in just a moment. Oh, you can.
And then I think,
Okay.
Julie, did you have another one online? No? Okay.
Okay.
Hi. Hello. So we would never suggest someone training for a marathon by doing nothing, yet women are about to embark on a 10, 20, whatever hour labor, and the conventional wisdom is to walk, do some yoga. Where do you, there's nothing wrong with those things, but it certainly doesn't train you for an endurance event. Where do you think this fear-mongering comes from?
Goodness, I think, and this is just Sarah's opinion, I think some of it's social. Like women are delicate, just put them in goodness, if you look at like old queens of England, like you like go into a room for months and you just lie there. I think some of it's social and cultural, but I also think that it's hard to study pregnant people because over the years we have conventional care and it is what it is. Now to change that convention, you're going to have to do a study and be really convincing. But what you're going to have to do to one of those groups of pregnant people is something that is not conventional. Right? So, changing the guidelines and stuff can be kind of tricky because you would have to do like a ethics and IRB approval and have women do stuff that isn't usually done. So that can be tricky. And really, what we do know is that as far as women being active, is that if they can be more active, there's a lot of good things that happen for them and the baby. Would I suggest someone who's coming into me 6 weeks pregnant that they start training for a marathon? No. But if someone is currently training for a marathon or a weightlifting competition or anything else, golly, keep at it until, you're being monitored by your OB. It's not my job to stop you. It's my job to help you keep doing it for as long as you want. So I think things can change. I think if women want them to change, we can change them. But we need to do more reports and case studies and grow that. Yeah, I think it's being pregnant and having babies is not for wusses. Katie?
Thanks, Sarah. Just to follow up to that question, so what do you do or say when a pregnant woman says, my OB told me to be very, very careful, but it doesn't make sense because I was really active the week before I got pregnant, and they don't have any other health risks, they don't have any other high-risk signs for pregnancy, and it just seems to be that that clinician's opinion that's ill-informed?
Yes, and so, sometimes I'll be honest, and I'm sure we've all experienced this, where you say one thing and then what is heard is another. So maybe what she said was like, I hear you're training for a marathon, be careful. Not like, be careful, stop everything you're doing. So I think clarifying that is very, very important. And then especially, so if they're seeing us, they're coming to us with a complaint of some sort. And if that, so let's say they were having low back pain or hip pain, even when people aren't pregnant, doctors will commonly say, well, why don't you just stop, right? So, if we take it back a step and look at it like that, if we can make their hip feel better, can they run? Or if they can run and their hip doesn't feel worse, is that okay? And to really circle back with that doctor, hopefully you can have like a nice little three-way conversation to make sure you're all on the same page of that the baby is safe, that the mom is safe, and that if this is an activity that's important to the woman, that she's able to keep doing it for as long as she would like to be able to. Goodness, so many questions. I still have 4 more minutes.
Yeah.
I know.
Thank you. But do you have an opinion on cosmetic surgery for fixing diastasis? Because I've been asked, will it improve my function? I mean, for cosmetic purposes, they want to get it done, but I don't have any experience.
So I have opinions. What I will tell you is I've only had one patient in my 15 years actually go through with that, and it was primarily for aesthetics. This is also a person who has like a team of people she sees for care. She's very into maintaining herself, which I think is awesome. I saw her over the course of 3 babies, and now the youngest one is like 5, and she finally decided to have it fixed. And what she told me was that she felt more grounded and connected, and that she was not pleased with her belly button. As far as function, she was already back to doing everything she wanted. So other than feeling like she felt like more, like she described it as more grounded, but she had like some like SI joint complaints. She said that was better. However, she still comes to see me about 4 times a year, so for that complaint, so I don't know. I would say, my opinion would be for that, is that if a woman is considering it, to get really strong, get as active as she can beforehand, and think about it, and see if that meets her goals. Because even if it does not, if she goes in to have that surgery, one, abdominoplasty, not easy either, not for the weak of heart. And so if she's going to go do that, she wants to have the best foundation possible to get the results that she wants. So if it is primarily aesthetics, I'm not here to judge, but she's going to want to go in with as good as a foundation as she can.
Good. Another question?
Heather, I was hoping you could touch on pubic symphysis diastasis. How often you're seeing that, what the research says?
Yeah, so what the research says is there does seem to be a little bit of separation, but a true diastasis, like pulling apart, doesn't actually happen that frequently. I have seen one person during a twin delivery actually separate. That's a problem. She had to have that externally fixated. But I don't see it lots. So a lot of women, I think what actually is happening is things are moving more. And again, I think it tends to be more of it's not that it's moving too much, but it kind of gets stuck in one position. And then trying to get things to move as well as possible. And like I said, that's where a belt can come in handy. I haven't seen it typically be an ongoing long-term problem after delivery. So I kind of just look at it functionally. If the belt feels good, awesome, but I really haven't seen any studies, and we actually don't even know what normal pubic symphysis width is, so I just treat it clinically, really. Is that helpful? Okay.
We've got a question up here in front, and while the microphone is, I'm sorry. You did have your hand up first, sorry. These are going to be the last 2 questions.
So I just have a quick question regarding if you think physical activity during pregnancy has been linked to the ability to have a natural birth, because my wife stayed really active during her pregnancy. She actually was at CrossFit the day we had a baby. It reminded me a lot of that marathon runner, but she was able to have a 17-hour, no meds, no epidural birth. So I didn't know if there was any link between, staying active during pregnancy with being able to have a natural birth.
I don't know the answer to that. I would suppose that being in better shape for an endurance event such as delivery would be great, but I also think that's where we get into the psycho and the social as well. Because if you have like the to get through a marathon and you just get a medal and a banana, and then you have labor and delivery where you get a baby at the end, I feel like that might be super motivating. And if I have that mindset, you know, I'd say that would be a helpful skill to have.
All right, the question right here in the second row.
Sarah, thanks a lot. This was great. I'm a labor and delivery nurse. I've been for 25 years, so this was wonderful. Just anecdotally, a lot of what you're saying is correct. When I look at my career in this area, we moved women a lot when I first started. And then somehow we ended up putting them in a bed. And we increased our C-section rate dramatically. It was very, very evident, to the fact that now California has a vaginal birth initiative.
Oh, seriously?
Yeah.
Go vaginas.
I know, right? It's an amazing concept. We were designed that way, but why didn't we use it? But anyway, so besides that, and really what it comes down to is going from a psychosocial perspective. It's not really about the biology. Women can tolerate this. They do really well with it. But it's also interesting to see that when we challenge kind of like exercise and movement and getting women moving when they're in their early stages of labor, instead of lying down, doing exercises, doing various things, that it actually works better. And it's interesting to see that and I'm not insulting any physician, hopefully, but it's often that's where a little bit of our obstacles lie. Also, how women deliver, that's a convenience,
Right.
not how they desire to do it. So yeah, it's kind of interesting. And then also from the pain perspective, I think a lot of us miss, and I would say all clinicians miss, nurses we do as well when we triage patients, is that we're missing that psychosocial component. Violence against pregnant women is pretty extreme, and there's a lot of issues around that. And so we do now take initiatives to ask about safety, ask about concerns that they might have, because we think that drives some of the pain that we see women coming in with, that physicians might label as round ligament pain, et cetera, really fall in a different realm.
Yeah, very true.
Thank you.
Yeah, thank you.
All right, thank you, Sarah. Thank you very much.
Thank you.